ladies and gentlemen, and honorable meeting participants. Thank you very much for the host excellent introduction of this meeting. My name is Amorat Ratanasiri. I work at Department of Community Medicine, Faculty of Medicine, Khon Kaen University, Khon Kaen Province, Thailand. Today, I will present our research title, Caring for Women Who Face Gynecologic Cancer in the Northeast of Thailand since 1985 via poster presentation. Let's go to the background. Cancer is a major health problem over the world. In Thailand, most women face psychosocial and economic problems, self-stigmatization and sexual relation from gynecologic cancer. Coping mechanisms and special care are needed for those patients in the northeast of Thailand. For the objective of this study is to synthesize knowledge about illness experience, coping mechanism, and the healthcare system being utilized with gynecologic cancer patients in Northeast Thailand. For the methodology, the review the result of the author's research in 3 steps as follows. In step 1, to synthesize content from staff and students at Khon Kaen University about gynecologic cancer patients in the northeast of Thailand. Step 2, to report illness experience of 3 gynecologic cancer cases. And step 3, summarize caring procedure for women who face cervical cancer, breast cancer, and ovarian cancer in northeast Thailand. Most research studies were based on secondary data. Some of them gave more information during in-depth interviews. Those who volunteered signed the consent form. The research review was approved by the Ethics Committee for Human Research of Khon Kaen University, Khon Kaen, Thailand. Let's go to the results. The result of this study had 3 steps as follows. In step 1, we reviewed illness experience, coping mechanisms with stigmatization, and healthcare system utilization for gynecologic cancer patients in northeast of Thailand. In step 2, we report caring system for cervical cancer, breast cancer, and ovarian cancer case as follows. For case of cervical cancer, we found that most cervical cancer patients face with pain, sexual relation, and stigmatization. For breast cancer, most breast cancer patients face with self-image and stigma because they believe of karma. And for ovarian cancer, most ovarian cancer patients believe that illness was because of karma. We have 3 cases present, for example, in the poster. To summarize, coping mechanism and special care for cervical cancer and breast cancer and ovarian cancer, we can summarize that cause of cervical cancer is a cause of human papillomavirus. Statistics report that cervical cancer in 3rd place in the top 5 cancer among the Thai people in 2022. Thailand reports that 140 new cases 140,000 new cases or 400 cases per day. Approximately 4,500 cases die per day, or an average of 8 to 10 cases die per day. To prevention of cervical cancer, we use a HPV, human papilloma virus vaccine to the patient or the girl at 9 years old or 11 years old to 26 years old to avoid having the cervical cancer, and that girl need to avoid having multiple sexual partner. To control by reducing the risk factor of cervical cancer, we screening the cervical cancer by pap smear, HPV DNA test, colposcopy examination, or endocervical curette. Treatment by surgery, radiation, chemotherapy, or combined treatment. For patients' quality of life, most patients suffering from this illness face stigmatization, fear of divorce from husbands, and suffering from having a sexual relationship. Caregivers and attending physicians must understand and provide assistance to improve those patients' quality of life. For breast cancer is the first cancer found in Thai people, both male and female. It is an unknown cause, found only abnormality of cells in the breast. Statistics report that 80% found an abnormality in the MU2, and 10% found an abnormality in mammary glands. To prevention is by cell examination on the regular basis. To control by paying attention to the 12 risk factors of breast cancer, including sex, ethnicity, having a child, sex hormones, age, obesity, breast tightness, history of drug use for breast treatment, heredity, alcohol drinking, cigarette smoking, and had breast cancer before. To screening by clinical breast examination or mammogram or ultrasound or needle biopsy or multiple methods. Treatment by surgery, radiomastectomy or radiation therapy or chemotherapy or endocrine therapy or biological or target therapy or combined treatment. For patients' quality of life, most of them suffer from this illness. Feel the loss of self-image, face stigmatization, fear divorce from her husband, and some cases fear death. Caregivers and attending physicians must understand and help them to have a better quality of life. For ovarian cancer is an unknown cause. It is associated with heredity, obesity, early menstruation, age less than 12 years old or late menopause, age more than 55 years old or infertility, or use of ovulation stimulation drugs. World Health Organization report that ovarian cancer is very commonly found after breast cancer. It is the first place cause of death in women over the world. To prevention of ovarian cancer can be done by eating a balanced diet, exercise regularly, having emotional stability, and receiving treatment for ovarian disorder. To control by reducing risk factor or avoiding eating fatty food, living in a good environment far from chemical. Screening for ovarian cancer in case of having risk factor should see an obstetrician regularly, have an internal inspection annually, or do blood tests. For finding more protein CA-125 than normal. The treatment is different in the 4 stage of cancer. In stage 1 cancer is in the ovary. For stage 2 and stage 4 cancer has spread to other organs. Treatment including surgery, chemotherapy, radiotherapy, and combined treatment. Patients suffering from this disease symptom and fear of death. Caregiver and attending physician must understand and support those patients from fear of death and help them to have a better quality of life. For the conclusion, health personnel in the health sector and the private sector, including caregivers, family, community participation, and health volunteers, must understand these 3 illnesses and kindly support them. We thanks on respondents for their valuable contribution to our studies. The Cancer Unit of the Faculty of Medicine for the data support. The Faculty of Medicine at Konkan University for funding support. Dr. Bang Onsi Jindawong and Mr. Pornput Pradapong for help prepare for e-poster. Dr. Pathama Chapanya and Dr. Tawanra Ratanasri for presentation help. Thank you very much for your attention. Any question, please? I am very happy to answer your questions. สวัสดีค่ะ
Yeah, and I'll share my screen. So this is regarding a study which was done in our hospital. So the topic goes on like comprehensive review of adnexal masses in a tertiary care hospital. So adnexal masses can be of ovarian, tubal, or para-ovarian origin. They may be detected either by physical examination, by a per-abdomen or a per-vaginal examination, or radiological imaging as a part of their evaluation of their symptoms, or by imaging which is done by done for any other indication. Acute surgical emergencies of gynecological origin can be because of torsion of the adnexa, cyst rupture or hemorrhage into the cyst. Ectopic pregnancy should also be ruled out if the woman is of a reproductive age group. So ultrasonography is the first choice for any imaging of any adnexal mass. In a pregnant woman, it is suitable for guiding surgical intervention if indicated. CT and MRI help in better diagnosis of differentiation of both malignant and benign conditions. Adnexal margins are of concern as malignant ovarian tumors have a high mortality rate. So we use the tumor marker CA-125 to assist in the evaluation of adnexal masses in appropriate patients. However, with this value alone, we cannot differentiate a benign and a malignant adnexal mass. But there is no effective screening method that is available for screening of ovarian malignancies too. So that is the reason why 70% of ovarian malignancies are diagnosed at a very later age stage. So the prevalence of asymptomatic adnexal masses is 0.17 to 5.9%, and symptomatic masses is about 7.1 to 12%. A proper clinical examination and a pre-operative workup is essential so that we can differentiate between a malignant tumor from benign ones. Early essential is needed, especially in adolescent girls, because we want to preserve their ovarian function. Asymptomatic, small and well-defined masses are usually monitored by periodic radiological evaluation. However, surgical management is needed if the cyst is large, symptomatic, or any features like solid components seen in ultrasonography. Large masses with complexity, projections, septations, irregularity, or bilaterally, when it is occurring either in the prepubertal group or the postmenopausal women, it may indicate it might be a cancer. So, radiological workup is needed, and we have to refer to an oncologist at the proper time. Early diagnosis and management will have about a 5-year survival rate of about 90%. The present study was aimed to determine the prevalence of different histopathological types of adnexal masses among the women who presented to our hospital. So, the aim of the study was to differentiate and to find out the prevalence of histopathological types of adnexal masses in different age groups. So, the method and study design is it was a retrospective study which was conducted in the Department of Obstetrics and Gynecology, Pondicherry Institute of Medical Sciences, Pondicherry, which is in India, from May 2019 to April 2022 over a period of 2 years. So, the all cases were sonographically diagnosed with adnexal masses and managed already. Ethical approval was obtained from the ethical committee of the hospital, and methodology included 31 study participants who were diagnosed with adnexal masses. So, the data regarding the age, symptoms, ultrasound findings, tumor markers, RMI score, mode of approach were collected from the medical record charts and were documented. Histopathological confirmed cases were analyzed and compared. CA125 was the tumor marker which we did mostly, and beta chorionic gonadotrophin, that is beta HCG, was also sent for women in reproductive age group. So RMI, so we calculate our RMI using the formula U into M into CA125. Ultrasound characteristics include bilaterality of the adnexal mass, whether it is present bilaterally, evidence of metastasis, evidence of solar components, multilocular cyst, and presence of ascites. So if none of them were found, the U was found to be 0, and if one character was found, it was 1 score, and if it was more than 2, the score was 3. Then menopausal status, if she was menopausal, postmenopausal, then it will be 3. If she was premenopausal, the score is 1. Then CA125 level was also noted. So with that, the multiplication was done. The ultrasound features menopausal status and CA125 value. If the RMI was found to be more than 200, it was considered to be positive. There were even cases of tubal ectopic pregnancies who were medically hemodynamically stable, so they were managed medically. Surgical approach, if it was done, it was by laparoscopy or laparotomy. So indications of surgery whom we have done was more than 8 centimeters, symptomatic people, or who had a persistent cyst even after the follow-up, or acute symptoms like torsion. They were all managed surgically. Then statistical analysis was a descriptive statistics was applied, and results were shown in the form of frequencies and percentages. So these were the results which we got. The demographic characteristics of the participants were studied. So out of 31 patients diagnosed with adnexal mass, 32.3% were in the age group of 30 to 40 years, and 9 women were found to be postmenopausal. So these are the number of cases. In 20 to 30 years, about 8 cases were there. 30 to 40, about 10 cases, which was the maximum. So they were in the reproductive age group, and 40 to 55 and more than postmenopausal was about 9 cases. So the most common symptom they presented with was they presented even without symptoms, or some presented with acute symptoms. So second common presenting symptom was mass abdomen. So the first was pain abdomen, which was found in 64.5% individuals, and 3 of them had torsion of the ovarian cyst, and they were taken up for emergency laparotomy. So second common symptom was mass abdomen, which was found in 16.1% people. 6.5% remained asymptomatic without any symptoms. Either they were diagnosed clinically or incidentally. So among different age group, whether it was ovarian origin or paramesonephric origin or ectopic, they were also classified and documented. Among 31 patients, 29.1%, that is 9 individuals, were diagnosed to have ovarian pathology. This included the one patient who had ovarian ectopic pregnancy, who was managed medically because she was hemodynamically stable. Paramesonephric cyst was found in about 12.9% individuals. Benign serous cystadenoma was detected in 28.6% of individuals, and most of them that is 14.3 were in the age group of about 40 to 50 years. Benign mucinous cystadenoma, these all comes under surface epithelial tumors. This was noted in about 21.4% individuals. These are found the maximum histological type in the age group whom we operated. And 14.3 were in the age group of about 30 to 40 years. Dermoid cyst was found in about 7.1% of patients, and mixed dermoid along with serous cystadenoma was noted in one patient who was postmenopausal. Borderline serous tumor was noted in one woman more than 50 years of age, postmenopausal, and bilaterality was found in 3 patients, 6.5%. So this is the table. So they were divided, these are the histopathological types and the age groups which were documented. Benign serous cystadenoma and benign mucinous cystadenoma were found in about maximum number of patients. So surface epithelial tumors were common, and dermal cyst was found in pre-pubertal age group and even in postmenopausal age group. Mixed dermoid and serous cystadenoma, other was lutein cyst, endometriotic cyst, paramesonephric cyst, borderline serous tumor, granulosa cell tumor, high-grade serous carcinoma. So these are the distribution. CA125 was found to be elevated in about 3 individuals, that is 10%. This is because even the endometriotic cyst will have a positive CA125 value. So that is why we don't rely on about only CA125, because that can be elevated even in pregnancy or endometriotic cyst. So they were elevated in 3 people. So we did not take them alone as an indicator for malignancy. Out of 28 patients, 2 patients reported an RMI of more than 200, and they had positive correlation with histopathological reports. That is, they were found to be malignant, and further management was done. So about of 31 cases, 2 were confirmed with ovarian malignancy. They also had a high RMI even before the surgery. One had high serous cystadenoma and the other had granulosa cell tumor. So hysterectomy with salpingectomy was done in most of the postmenopausal women. The surgical staging was done, and women with a younger age group, we did a fertility preserving conservative surgery. If one adnexa was involved, unilateral oophorectomy was done, and the other ovary was left in situ, since the girl was a younger lady. So 30 women were married and 8 were pregnant. So 8 pregnancy, it means that while pregnant, she also had adnexal masses like endometriotic cyst, and also they had ectopic pregnancy, which presented as an adnexal mass in ultrasonography. Benign masses are common in the age group of 20 to 49 years. So among 6 women more than 50 years, 4 had benign masses. Only 2 were malignant. So out of 6, about 12.9% had benign masses in postmenopausal age group. So when we go on to the discussion, the present study included 28 patients who were surgically managed with adnexal masses of size more than 8 centimeters, or those who presented with acute abdomen or with a suspicion of malignancy with a high RMI score. 3 patients of reproductive age groups were diagnosed to have ectopic pregnancy and medical management was done, whereas functional ovarian cyst was also diagnosed, which was just monitored in a periodic basis and they resolved. Some were given oral contraceptives over a period of time, and there was resorption of the functional ovarian cyst. So this also helped in distinguishing physiological cyst from a pathological one. So when a simple unilocular cyst is seen, and we do a serial ultrasonography and CA125 monitoring is done, so that unnecessary excision is avoided. A unilocular echo-free ovarian cyst to be malignant is less than 1.6%. Therefore, ultrasonography and tumor markers can aid in the diagnosis. However, histopathological examination gives the final confirmation. This descriptive study was undertaken to analyze and correlate the age group and presentation histopathological diagnosis in the patients who presented in our hospital over a period of 2 years. So in our study, the abdomen pain was the commonest symptom, as we already told. This was similar to the study which was done by Kayasta, and this was the incidence which was seen in their study too. The incidence of benign epithelial tumor was about found in 50% of cases. It was also commonest tumor encountered in the age group of 20 to 49 years. Similar findings were reported by a study by Pillai, Gupta and Kayasta. Asymptomatic masses that were discovered in the first trimester should be evaluated by ultrasound looking for features of malignancy. So if you are planning for a surgery in a pregnant lady, it is usually done in second trimester. if malignancy is suspected or if the patient is symptomatic. This is to avoid the risk of miscarriage if performed in early trimester or preterm delivery if performed later. So MRI is preferable whenever adequate evaluation of the mass is not possible by ultrasound. Even CT can be done. In the present study, 2 out of 8 pregnant women were operated during the second trimester as they were symptomatic. Cystectomy was done for these patients and they were followed up with obstetrically indicated cesarean section later on. Ovarian malignancy is rarely seen in the age group of 15 to 40 years. The functional, non-neoplastic and benign cystic ovarian lesions are common in younger age group. However, the chances of malignancy increases as the age advances. So, we recommend a screening of women more than 50 years if they present to the clinic with symptoms which are relevant to ovarian malignancy, because the screening is not always possible with ovarian cancers. So we used an RMI for preoperative evaluation to differentiate between a benign and a malignant adnexal mass. RMI has been useful in diagnosing epithelial ovarian cancers. So RMI was found to be elevated in a high-grade serous carcinoma. However, for other histopathological type of malignancies, it is not of much use. So a grayscale ultrasound with the color Doppler study along with IOTA analysis, that is International Ovarian Tumor Analysis rules, have shown to have a high sensitivity and specificity for prediction of malignancy in adnexal masses. In our present study, only RMI was calculated. However, we didn't follow the IOTA rules. So, if both were combined, they were of high sensitivity and specificity value. Because RMI can also be elevated in benign conditions like endometrioma. It was low in mucinous and non-epithelial ovarian cancer, thus we can miss out any other malignancies. Other scoring systems, we should include also other scoring system which have a high sensitivity and specificity. Conclusion: the most commonly encountered adnexal masses were benign and they arose from the ovary. Benign epithelial tumors were mostly encountered in our study too. This was followed by para-ovarian cyst and endometriotic cyst. Ultrasonography is of much importance in differentiating the benign from malignant masses, as they have specific features like solid component septations, bilaterality, ascites. In cases of ovarian tumor, which is asymptomatic, and those who have regular morphological features, interval monitoring is done because we don't jump into surgery so that the ovary is preserved. So, we need a selective and tailored surgery which is done for women requiring surgical management. Ovarian preservation is our main goal so that long term morbidity is avoided. Combining a grayscale ultrasonography along with IOTA rules are recommended in predicting cancer. In case of suspicion of malignancy, early and prompt referral to an oncologist is advised. So these are the references. Thank you.